Hi, my name is Jacqueline Bitsavich, and today I will be presenting the cardiovascular accident presentation. My objectives for this presentation is to discuss what a cerebral vascular accident, or CVA, is and the type of CVAs, identify the unique characteristics of the types of CVA, explain the nursing assessment for a patient experiencing a CVA, describe modifiable and non-modifiable stroke risk factors, explain the typical diagnostic tests and treatment modalities of CVA, discuss assessment findings to the underlying pathology of the affected area of a CVA, list the medical management and commonly used to treat a CVA, and explain nursing diagnosis and interventions related to a CVA. I wish I could present this to you in a classroom, but unfortunately, due to our circumstances, I'm going to be doing a PowerPoint with voiceover for you. I wish I could receive some of your questions or comments and explain a little bit more in detail, but this is the best we can do. I want to begin with some stroke statistics. A CVA is a medical emergency. A CVA or stroke can happen to anyone at any age, from infancy to the elderly. Some stroke statistics. Every 4 minutes, on average, 1 American dies from stroke. 130,000 Americans die from a stroke each year. 795,000 people in the United States have a stroke each year, and most are new strokes. However, 1 in 4 are recurrent strokes. 49% of Americans have at least one risk factor for stroke. 34% of people hospitalized for stroke were under the age of 65. 87% of strokes are ischemic, and an ischemic stroke, I'll get into more detail about this, happens when the blood vessels to the brain are blocked either by plaque, rupture, or embolism. Strokes are the leading cause of disability in adults. 90% of survivors have a residual effect. Moderate to severe disability is seen in 70% of survivors. An estimated 15 to 30% of stroke survivors are permanently disabled, and 20% require institutional care for 3 months post-stroke. Nearly 1 out of every 18 deaths is caused by a stroke. The American Heart Association estimates that there are currently over 7 million stroke survivors in the United States. What is a CVA? It's a sudden loss of neurological function caused by an interruption of blood flow to the brain. The types of cerebral vascular accidents, or CVA, is ischemic and hemorrhagic. Hemorrhagic is a stroke in which the blood leaks into the brain tissue, and an ischemic stroke could be caused by a clot or thrombus that stops the blood flow to an area of the brain. I'm going to get into much detail about both of those. I want to begin with a little bit of pathophysiology of a CVA. Ischemic or hemorrhagic, there is an interruption of the blood flow to the part of the brain that results in tissue hypoperfusion, tissue hypoxia, insufficient glucose, and brain cell death. Ischemic stroke process initiates by a sudden interruption of cerebral blood flow, thrombus formation in a vessel, a platelet aggregation process caused by the exposed subendothelium. The platelets release adenosine diphosphate, or ADP, that causes platelet aggregation and consolidation of a platelet accumulation. Thromboxane A2 is released, contributing to platelet aggregation and vasoconstriction. The damage to the vessel activates the claudication cascade that can lead to thrombin production, causing cell necrosis. Thrombin converts fibrinogen into fibrin, which can lead to a clot formation as fibrin molecules, platelets, and blood cells aggregate. This triggers inadequate energy supplies, failure to neural activity, and regional brain dysfunction. A CVA stroke concepts activate a cascade of cellular consequences that are complex and dynamic responses to exotoxicity, mitochondrial dysfunction, and oxidative stressors. Exotoxicity and calcium overload are the key contributors to early stages of cellular demise. Ischemic central zone is the infarcted neuron's permanent loss of function. The lack of nutrients available to the neurons after stroke disrupts the ionic gradient, resulting in excess release of excitatory amino acids, mainly glutamate, driving into the intracellular calcium influx and setting in motion the apoptotic and necrotic pathways. Here's a picture of the severe ischemia. The quicker reperfusion of the penumbra, once the less damage and optimal outcomes. The penumbra is the surrounding area with minimal perfusion can be potentially viable. The release of necrotic cells induces apoptosis and inflammatory cytokinase that cause the death of the cells in the vicinity of the infarction and aggravates the brain injury. Other contributors of stroke pathology are protein misfolding as a result of excess calcium, glial damage, and broader pro-inflammatory reactions. Cellular insults incurred following a stroke, neural circuits are also disrupted due to the shifts in the excitation inhibition balance in the neural networks. The gamma-aminobutyric acid, or the GABA, is the neurotransmitter that sends chemical messages through the brain and the nervous system and is involved in regulating communication between the brain cells. The role of GABA is to inhibit or reduce the activity of the neurons or nerve cells. Modulation of the tonic inhibition regulate the GABA, the A receptors, has shown to facilitate functional recovery. Improved regulation and a well-developed understanding of how the excitatory and inhibitory balance is disrupted after a stroke is critical in designing therapeutic approaches in stroke recovery. Each component of the pathophysiology response following a stroke on both the cellular and circuit levels responds to the opportunity for limiting initial injury and hastening recovery. The diversity of having a stroke, and it is patient-specific situations and characteristics. Some patients can develop collaterals and vasculature composition that helps reroute the circulation to help the brain function better. Patient selection is critical for the ultimate success of the rehabilitation. In the advanced ischemia is the loss of function as explained causes an accumulation of glutamate and aspartate in the extracellular fluid, causing cell damage, which is aggravated by the lack of oxygen and glucose, which binds to the NMDA receptors, triggering an influx of the water, sodium, and calcium destruction of the cell components and formation of free radicals. That's a little bit of the pathophysiology of a stroke, of an ischemic stroke. Causes of ischemic stroke. Here's a little picture showing the potential causes. It shows from the carotids up into the vascularization from the large vessels, and I'm going to get in more detail about this, into the smaller vessels. In their thrombotic, large vessels, small vessels, like I say, could be embolic, which is cardiogenic, cryptogenic, and vasospasm. Large vessels and small vessel thrombotic strokes. Large vessels are included to contain the anterior cerebral arteries, which is the ACA, or your middle cerebral arteries, which is the vessels that branch right off the brain into the hemispheres. Posterior cerebral arteries, which is the PCA, then goes into the smaller ones, which would be the vertebral and basilar arteries. Smaller vessel lacunar infarcts are smaller infarcts to the deep vessels, which are the basal ganglion, the brainstem, and the pons. Embolic strokes could be cardiogenic, which is a blood clot that travels to the brain from either a clot passed from AFib or cardiac arrhythmia or thrombus. It could be plaque from atherosclerosis areas in the cerebral arteries. Cryptogenic stroke, a patient has all of the workup, but nothing significantly prevails as a cause. So it is classified as a stroke of unknown cause. Even if they rule everything out by MRIs, CAT scans, everything, they just can't figure out what the cause was. Potential other causes could be transischemic attacks, migraines, illicit drug use, synthetic marijuana, cocaine, methamphetamines, coagulopathies, or dissections of the main arteries, the carotid or vertebrals. Vasospasm is a reduction in the blood flow to the brain occurs due to the red blood cell hemolysis releases a chemical reaction that causes arterial constriction. And I'll get into a little bit more detail about that. Causes of hemorrhagic stroke. Here's another picture that shows the main vessels going up from your carotids up into your mean cerebral arteries. And I'm going to go into a little bit of pathophysiology, and then I'm going to explain a little bit more of the causes of the hemorrhagic strokes. A review of the pathophysiology of a hemorrhagic stroke is a process initiates when a blood vessel becomes weak or burst, causing bleeding within the brain parenchyma and within the surrounding space, resulting in compression. The bleeding can stop or continue to enlarge. Arterial hypertension causes hyaline degeneration and fibrinate necrosis in the weakened arteries that supply the brain. Brain tissue swelling and damage results in inflammation and edema caused by thrombin and other blood products that can lead to the Monro-Kelly doctrine or hypothesis. I know you have already this been explained before, but I'm just going to explain a little bit more about it. And it is the sum of the volume of the brain tissue itself, CSF fluid, and intracranial blood, which is constant, in which the interrelationship of the volume and the compliance of the brain tissue within the skull is the brain is 80%, 10% is the blood component, and cerebral spinal fluid is 10% component within the skull, having an effect on the increasing and intracranial pressures that can lead to herniation. So if there's a bleed in the brain, it compresses more of the brain tissue, which can have a reflux with the CSF fluid. So if there's more blood contained in the brain, the skull is a solid component that it has to be more compliant with that. So if there's an increase of brain tissue from edema, then that can also have an effect on the recirculation of blood and the recirculation of CSF fluid. So it's an ongoing relationship in the brain. 13% of strokes are hemorrhagic, and major complications of either types of stroke is it's a medical emergency, and you have to immediately go to the hospital for medical attention for optimal outcome. Immediate identification of the onset and the manner of stroke is determined of proper treatment. A stat CAT scan needs to be completed so the physician can identify what type of stroke the patient is having. Early signs and worsening signs need to be immediately identified. And then common causes of hemorrhagic stroke is hypertension, trauma, aneurysms, arterial venous malformation, and bleeding disorders. And I'm going to get into a little bit more detail. So the hypertension is the main risk factor for strokes, which can be due to hypertension crisis or uncontrolled hypertension. Trauma to the brain, either being hit or traumatically jolting the brain around. Aneurysms, and I will explain that more in detail. AV malformations or arterial venous malformation is the abnormal collection between the arteries and the veins without capillaries between them. AVMs are congenital defects but are not hereditary. And bleeding disorders or coagulopathies are there can also be an underlying brain tumor that a patient may have that can be causing a hemorrhagic stroke. Hemorrhagic stroke classifications occur within the brain or between the brain and the skull. A general overview is an intracerebral hemorrhage, which is also known as an ICH, within the cerebrum or the brain tissue itself. An ischemic stroke can hemorrhagically convert or lead to intracerebral hemorrhage. 50% of intracerebral hemorrhage patients die. Interventricular hemorrhage, or an IVH, is within the ventricles, that patients have a hemorrhage within that area, which will also block the flow of the CSF fluids or cause hydrocephalus, and also can have vasogenic or cerebral edema, and also have an effect on the brain tissue. Subdural hematoma is bleeding occurs within the subdural space, which goes back into reviewing of the different components of the brain. And subarachnoid hemorrhage, or SAH, it most often happens because of saccular aneurysms. These are very critically ill patients. Some of them can come in and be talking, and within hours they can decompensate. The typical hospital stay is about 21 days. The most difficult days for a subarachnoid hemorrhage patient is within the 7 to 10 days, and this is when peak occurrence of vasospasm, and I'll get into detail about that. Some Subarachnoid hemorrhage patients are on multiple drips. They can be on hypertonic 3% saline solution. They can require mannitol to help with the vasogenic edema. They're closely monitored. We're watching their ICPs, and sometimes they have to have an external ventricular device inserted, and we're constantly watching that, so that avoiding any potential herniation of their brain. We're assessing for non-communicating or communicating hydrocephalus. We're assessing their electrolytes for hyponatremia. We're assessing the patient, monitoring their intake and output for hypovolemia or euvolemia, keeping the vessels plump and patent. If fluid is depleted, can result in vasospasm. Assessing the patient for also if they start to dump urine, or they could be going into cerebral salt wasting, that their body is just excreting the sodium in their urine, or diabetes insipidus, where they're just getting rid of the extra fluid. And we also do triple H therapy, which is hypervolemia, hypertensive, and hemodilution. We're trying to keep the patients more positive in their fluid volume, so that their vessels constantly keep circulating to help with the blood flow. A subarachnoid hemorrhage is a sudden onset of the worst headache of a patient's life. It also could be a thunderclap headache and ruptured aneurysms. There are two possible causes of a hemorrhagic stroke: a ruptured blood vessel in the brain. The most common is an aneurysm. An aneurysm is a weakened area in the wall of a blood vessel that causes a blood vessel to bulge or balloon out in swelling and rupture, or can possibly rupture. Women tend to have a higher rate of aneurysms than men. Common occurrences in the age older than 40. Some are possibly due to birth defects. Some are hereditary, or there can be a family history. And usually it's like a mother passes it on to their children. It could also be brothers and sisters, or first generation family members. Aneurysms lead to form where vessels branch off or at forks of blood vessels. And these tend to be weaker, like in the circle of Willis or at any bifurcation. I want to explain a little bit of the types of aneurysms. There are saccular aneurysms, which is a sac-like bulging in the wall of an artery, and they're also known as Berry aneurysms. There's fusiform aneurysms, and has an equal outpouching on all sides of the aneurysm wall, and there is no stem. And there's also dissecting aneurysms, which is a collection of blood that leaks out in the artery of the vessel, or it could be in the interparenchyma of the vessel, causing weakness and or dilatation in the vessel that can sometimes form by trauma or head trauma. Common vessels for aneurysms are found in the base of the brain, which could be the PCOM, the ACOM, basilar, the middle cerebral artery, the posterior cerebral artery, PCA or the MCA, and common treatment is mainly blood pressure management. A rare cause of an intracranial hemorrhage is an AVM, like I explained, and the treatment focuses on controlling the bleeding and reducing the pressure caused by the bleeding or the cerebral edema and vasogenic edema. Nursing assessment of a patient experiencing a CVA. The acronym BFAST. B stands for balance, which is loss or coordination, or dizziness or severe headache. E is eye, difficulty or loss of vision in one eye or both eyes, also blurred vision. F stands for face, which is drooping or asymmetry. Arm is drift or sudden weakness, either an arm or leg on one side. Speech, change in speech, slurred speech, difficulty speaking, or lack of understanding or communicating. And time is of the essence. It's the key is time is brain seeking immediate medical attention. Also, nursing assessment is completing a nursing neurological assessment, which is assessing cognition. You want to assess the patient for alertness if they're lethargic, obtunded, stuporous, or comatose. You want to assess a patient's orientation for person, place, time, and situation. Assess pupillary response to light, making sure that their pupils are equal, round, regular, or irregular. Assessing accommodation if they both react at the same time, and reactiveness, making sure that the pupils are brisk, sluggish, or fixed. Assessing extraocular movements, assessing for any visual field loss, impairments, or visual field cuts, hemianopsia, change in their vision, blurred vision, or diplopia, any deviation in their eyes. Are both eyes conjugate or are they disconjugate? You're assessing the patient for facial symmetry. Is there any facial symmetry or asymmetry or drooping? You're going to assess their tongue position. Is their tongue midline or does it deviate to the right or the left? You're going to assess their cranial nerves, and I'll get into a little bit more detail about that. Assessing their speech to make sure it's clear, spontaneous, and logical, or if their speech is dysarthric, that they can't form the words or get the words out. If their speech is slurred, garbled, or if the patient is having any expressive or receptive aphasia, or if they're having global aphasia, which they cannot understand or speak in that essence. Assess the patient's extremities. You're assessing their motor, their strength, their range of motion to detect if there is any weakness, if they're flaccid or hemiparesis or hemiplegia. You also want to assess their balance and sensory. You're going to do, I'm going to get a little more detail in the NIH stroke scale with assessing finger to nose, ataxia, and also running their heel from their knee down to their shin bone and up and down on the right and the left, assessing both sides if there's any deficits, if there's any sensory loss. You're going to do a touch test with the pinprick to test for sharpness or dullness, or whisks of cotton to see with pressure or vibration. You're also going to assess temperature of hot or cold. In some patients, they may have effects, and other patients have no sensory deficits, or sometimes they can have weakness, or they can have sensory loss, but they can have function. So it's patient specific with all these assessments. You're going to also assess for any numbness, tingling, ataxia, paralysis, neuralgia, dizziness, fainting, confusion, change in memory, any hearing deficits, balance, gait, changes in chewing or swallowing problems. And the patients can have subjective complaints where they are unable to move or feel a hand or arm or leg, or objective complaints from the patient by assessing the patient's their strength in all their extremities and or assessing the patient's cranial nerves. And I'll get into more detail about the cranial nerves. Assessing the Glasgow Coma Scale, and this it's a stroke assessment scale, which aims to give, which aims to give a reliable and objective way of recording the state of a patient's level of consciousness for initial as well as subsequent assessments. The scale assesses eye opening, verbal response or performance, and motor responsiveness of the patient and to their appropriate stimuli, and is also estimates the coma severity. So you're going to follow the patient's best reaction by assessing the patient's responses and scoring accordingly per the scale. So you have the patient open their eyes. If they can open their eyes spontaneously, they would receive a 4. If they only open their eyes to sound, they would receive a 3. If they only open their eyes to pressure, they would receive a 2. And if they don't open their eyes at all, no eye opening, they would receive a 1. Verbal response, if they are alert oriented, times 4, they would receive a 5. If they're confused, they would receive a 4. If they only verbal response or some words, would be a 3. They only make sounds that you can understand, would be a 2. If there's no sound at all, if the patient is intubated, then they would receive a 1. Best motor response of the patient, if they obey commands, they would receive a 6. If they only localize to either tactile or painful stimuli, they would receive a 5. If they have normal flexion or withdrawal, that would be a 4. Any abnormal flexion, they would receive a 3. If they have extension or abnormal extension, if they're posturing, disorderate or corticate, they would receive a 2. If there's no response at all, they would receive a 1. And this is on a scale is based on the best score is a 15. So they are mildly impaired if they're between a 13 and 15. They have moderate dysfunction if they are 9 to 12, and severely impaired if they receive a 3 or an 8. And this is commonly used for medics test for EMTs and paramedics. Now I'm going to explain about the ischemic stroke assessment scale, which is the NIH, or the National Institute of Health Stroke Scale. And this is complete the NIH stroke scale mainly is for ischemic CVAs, which is a 42-point scale that quantifies the neurological deficits that is a prognostic tool to identifying potential outcomes assessed for daily function. The NIH stroke scale was developed to help physicians objectively rate the severity of ischemic stroke. The tool evaluates the area involved from the stroke. Hypoxia that can cause confusion or delirium. Increasing the score indicates the more severe the stroke and has been shown to correlate with the size of the infarction on both CAT scan and MRI evaluation. The NIH stroke scale is a standardized method used by healthcare professionals to measure the level of impairment caused by a stroke. The main purpose or use is a clinical assessment tool to determine whether the degree of disability is severe enough to warrant the use of alteplase or TPA. And I'll get into that with medical management. Another important use of the NIH is research, whereas to allow for the objective comparison of the efficacy across different stroke treatments and rehabilitation intervention. The score is totaled to determine the level of severity and can also serve as a tool to determine if a change in the exam has occurred. Usually, I work at a neurointensive care unit, and we do this once a shift or if there's a change in the neurological status. There's 13 item scoring system, which takes an average about 7 minutes to complete the exam. It integrates the neurological exam components, the cranial nerves, I'll get into detail about that, is visual, motor, sensory, cerebellar, intonation, and language and level of consciousness. The maximum score is a 42, signifying severe stroke, and the minimum score is a 0, which is a normal exam. The score of 1 to 4 is a minor stroke deficits. The score of 5 to 15 is moderate stroke deficits. 15 to 20 is moderate to severe stroke deficits, and a 21 to 42 is severe stroke deficits. Initially, you begin with the level of consciousness. If a patient is alert and keenly responsive, they would receive a 0. If they are not alert but arousable by minor stimulation, they would receive a 1. If the patient is not alert and requires repeated stimuli, either tactile or verbal stimuli, they would receive a 2. If the patient is unresponsive or responds only with reflexes, which would be like your cough, your gag, corneal reflexes, they would receive a 3. You're assessing their level of consciousness questions. What month is it? What's your age, your name, what your location is. If the patient is able to answer 2 questions correctly, they receive a 0. If they answer only 1 question correctly, they receive a 1. If the patient answers neither question correctly, they receive a 2. And that would be if a patient is intubated or if they're completely globally aphasic. And you're assessing the patient at the best optimal opportunity or their best effort that they're giving towards you. And don't change your initial response. The level of consciousness following commands, if they open their eyes and close their eyes, if they grip and release their hand. If they're able to perform both tasks correctly, they receive a 0. If they perform one task correctly, they receive a 1. If performs neither task correctly, they receive a 2. You're assessing the patient's best gaze. If it's normal gaze, this is 0. If they have partial gaze palsy, they would receive a 1. If they have a forced deviation, they would receive a 2. Visual. If there's no visual loss, they receive a 0. If there's partial hemianopsia, which they can only partially see to one side, if they have a field cut deficit, they would receive a 1. If there's complete hemianopsia, that they are completely unable to visualize or have neglect, they'd receive a 2. If there's bilateral hemianopsia, they'd receive a 3, that there's complete neglect, visual field cut. You're also assessing patient facial palsy. If normal facial symmetry movements, they'd receive a 0. If there's minor palsy, if it's just upper face, they'd receive a 1. If it's partial paralysis, they'd receive a 2. If it's complete paralysis on one or both sides, they'd receive a 3. You're assessing their motor in their arms, in their left arm, right arm, where you have if the patient extend their arms out in front of them as if they're holding a pizza box, and you're assessing if they're having a drift in one arm. And as the patient holds their arms out in front of them, you have them close their eyes. And if they have no drift, they'd receive a 0. If they have a slight drift, they would receive a 1. If there's some effort that the patient is trying to lift their arm off the bed, they would receive a 2. If there's no effort, they have hemiplegia, they would receive a 3. If there's no movement at all, they would receive a 4. Then you're having them do the limitaxia, which is the finger nose, that you have the patient touch their nose, touch your finger, and you move your finger to check if they have any ataxia. If is absent, that they are able to follow the commands and complete the task, it was a 0. If there's present in one limb, like one arm, then they would receive a 1. If it's present in both arms that they are unable to follow, they would receive a 2. You're going to check their sensory to make sure if it's normal sensory with no sensory loss, they would receive a 0. If it's mild to moderate sensory loss, you'd give them a 1. That would, if the patient, if you're pinching their nail beds or causing pain in their nail bed, they would receive a 1. Or if they're severe, that there's no response at all to total sensory loss, they'd receive a 2. You're assessing the patient's best language. If there's no aphasia and it's normal language, they'd receive a 0. If there's mild to moderate aphasia, you'd receive a 1. If severe aphasia, that they're expressive or receptive, they'd receive a 2. If they are mute, if they are intubated or globally aphasic, they would receive a 3. If the patient is dysarthria, if it's normal, they have good speech and are able to speak clearly and spontaneous and logical, they'd receive a 0. If they have mild to moderate dysarthria, that they are having difficulty forming their words or they're a little slurred or garbled, they'd receive a 1. If there's severe dysarthria, they'd receive a 2. You're assessing, the final one is extinction and inattention. So if there's no abnormality, that they're awake and there is no neglect, they'd receive a 0. If they're having any visual, tactile, auditory, spatial, or personal inattention or attention, they'd receive a 1. If they're profound hemi-inattention or extinction or complete neglect, they would receive a 2. After you do this assessment, you total up all of their score, and then you would get what their score is and would be significant, to tell what their deficit of stroke is. If it's minor stroke deficit or moderate to severe, or if they're severely profound stroke deficits. Patients have modifiable and non-modifiable risk factors. Commonly, it begins with that patients can have AFib or an irregular heart rhythm or cardiac arrhythmia, hypertension. You'll want to maintain a normal blood pressure, which is 120/80. Avoid smoking, which is a modifiable risk factor. Obesity, assess their BMI. Avoid unhealthy diet. You want to have a heart-healthy diet and make sure you're eating a balanced diet. You want to avoid low physical activity, usually daily exercise. You want to exercise for 30 minutes 5 times a week. Could be just walking, running, or going to the gym. You want to, if a patient is diabetic, try to maintain lower glucose levels, less than 140. Higher glucose levels have shown that there's worsening outcomes of patients. You want to avoid heavy alcohol. You want to consumption, because that can lead to more problems. You also want to, psychosocial factors can contribute as stress or any dysfunction in psychosocial factors. You also want to identify your lipid levels and cholesterol levels. You want to make sure that your cholesterol is less than 200. There's non-modifiable risk factors for preventing a stroke are age, gender, race, genetics, family history of a stroke, or chronic conditions. There are higher incidents of stroke in certain races, as African Americans have a higher tendency for strokes, Hispanics or Latino Americans. Greater occurrences in the age of older than 55 years old. Stroke happens more often in males than female gender. Genetic composition can have an effect predisposing the likelihood of having a CVA. Sometimes it could be vasculature, or if your family has diabetes or hypertension. One stroke factor that has been recognized by the public health authorities for having an unusual high incidence of stroke and other forms of cardiovascular disease is in the southeastern United States. It's considered the stroke belt. It's identified as 9 states in region consisting of Alabama, Arkansas, Georgia, Kentucky, Louisiana, Mississippi, North Carolina and South Carolina, Tennessee, and also sometimes considering Texas. In that area they have a higher incidence of cardiovascular disease and incidence of stroke It's just amazing in that area. It must be their genetics or their diet that could be causing this higher increased potential. Clinical manifestations, I want to get into explaining the left-sided strokes and right-sided strokes. I'm beginning with the left-sided. A left MCA finding can be significant to have right-sided hemiparesis or hemiplegia, so they could just have weakness or complete flaccid on the right side. They'll have right-sided hemisensory loss. They could be just numbness, tingling, or complete loss of sensation. They could have right visual deficit. They could also have a left lateral gaze, and they're more prone to having aphasia, speech control, or inability to speak or understand language or spoken words. They commonly have difficulty reading, writing, arithmetic, learning, organization, reasoning, and analyzing. Clinical manifestation of right-sided stroke patients, a right-sided MCA finding, they commonly have left-sided hemiparesis or hemiplegia. Again, either just numbness, tingling, just weakness, or they can be completely flaccid. They have a left-sided hemisensory loss. They could have a left visual deficit or left lateral gaze. And right-sided hemisphere strokes are unaware of their deficits. Some of these patients can have some of these symptoms, and it's always patient specific. So they may have some of them and they may not. They also, right-sided strokes have spatial awareness and ability. They have problems with depth perception and following directions. They commonly have flat affects, controlling of their emotions or emotional expressions, and they have sometimes nonverbal memory impairment. Now I want to get into explaining the lobes of the brain, primarily, which is beginning with the frontal lobe, and I'm going to individually explain a little bit more of the patient's symptoms that they can have. The frontal lobe is motor control, which is your premotor cortex, which is commonly problem solving, prefrontal area, and speech production, your Broca, which is your expressive Broca area. Your parietal lobe is touch and perception, the somatosensory cortex, body orientation, and sensory discrimination. The temporal lobe is your auditory processing or hearing. Language comprehension is your Wernicke area. Memory and information retrieval. The occipital lobe is your sight and visual cortex, visual reception and visual interpretation. Your cerebellum, which is your balance and coordination, and brainstem and involuntary responses. And I'll get into a little bit more detail of each lobe. The frontal lobes is your primary motor control strip, which is your right frontal. Stroke patients may present with mania, delirium, or delusions. The left frontal stroke patients, which is your Broca motor, speech, and understanding, presents with depression, diminished affect, and monotonous speech, that they have no fluctuation in their speech of either sadness or joy. And the patient's very flat affect. Lobes of the brain. Parietal lobe is located behind the frontal lobe. It's the primary sensory strip for touch, pressure, and position, proprioception, organizing and interpreting sensory information, responsible for taste. The temporal lobe is located on each side of the brain at the level of the ears, is responsible for hearing and smell, and commonly occurs is seizures. The occipital lobe is at the back of the brain, responsible for vision, visual cortex. Patients can have blindness, denial of their deficits, visual field cuts, illusions or hallucinations, or amnesia. The cerebellum is located at the back of the brain below the occipital lobe, is responsible for your posture, your gait, your equilibrium, and your balance. It also has fine motor skills, use of the assessing your finger nose, again with the NIH stroke scale, and finger to finger coordination. Posterior fossa, the posterior inferior cerebral artery, the pica, or the superior cerebral artery, the SCA, use a feedback loop system. And they could also, patients having a deficit in the pica or the SCA can have generation of their circulation, or if they can develop collaterals to help regain some of the lost deficits with the stroke. The brainstem is comprised of three components: the midbrain, the pons, and then submedulla oblongata. The midbrain is responsible for control of eye movement, visual field deficits, hearing impairment, uncoordinated body movements, involuntary eye movements, and assessing the extraocular movements, or the EOMs. Your pons is the largest part of the midbrain, contains the start of the cranial nerves, 5 through 8. I'm going to get a little more detail about the cranial nerves in a little bit. Controls the facial movement and transmitting sensory data. The medulla oblongata is the lowest part of the brain, which contains the cranial nerves 9 through 12, controls the center for vital functions, regulates your heartbeat, your breathing, your blood pressure, swallowing, GI function, the cough, gag, corneal reflexes, blinking, and shoulder shrug. Now I'm going to explain about the cranial nerves. I'll go into detail about that. I just wanted to show a little picture of where the cranial nerves begin in the brain, and here's a little picture of where they are on the face and the head and the neck, just to show and reference. The cranial nerve 1 is your olfactory, which is your smell. Cranial nerve 2, which is your optic, which is sensory only, which is your vision. Cranial nerve 3 is your ocular motor, which is both motor and sensory. It serves as the muscles of your eyes. 4 is your trochlear, which is motor and sensory, serves as the superior oblique eye muscles, checking your EOMs. Cranial nerve 5 is your trigeminal, which is your motor sensory for your face and your mouth, motor and muscles for mastication, chewing. Cranial nerve 6 is your abductus, which is motor and sensory, serves as the lateral rectus eye movements, which is doing your EOMs, or your extraocular eye movements. Cranial nerve 7 is your facial, which is motor and sensory, serves as muscles of the facial expression, lamictal glands, and the salivary glands. Cranial nerve 8 is your vestibular cochlear, which is sensory only for equilibrium and hearing. Cranial nerve 9 is your glossopharyngeal, which is motor and sensory, serves as the pharynx, the throat, for swallowing. Posterior third of your tongue, your parotid salivary gland, so patients will have difficulty swallowing. Vagus nerve, your cranial nerve 10 is your vagus nerve, which is motor and sensory, sensation for visceral internal organs, and parasympathetic motor regulation of visceral organs. Cranial nerve 11, is your accessory, which is motor and sensory, serves as the muscles that move your head, your neck, and your shoulders. So you're going to assess for the rotation of their head, shoulder shrug. And cranial nerve 12 is your hypoglossal, which is your motor and sensory, serves as the muscles of the tongue to show if there's any deviation. You'll have them move their tongue from side to side and see if there's any deficits with their tongue. In cooperation with this, you could also, interdisciplinary teams will assess this. PT, OT, and speech. Speech will assess the patient for any difficulties chewing or swallowing. Common diagnostic testing for stroke patients, initially, especially if there's any stroke-like symptoms, is a CAT scan. A patient could be having stroke-like symptoms, deficits, which can be mimicked as from either being intoxicated, hypoglycemia, hypotension, or hypertension. A CT angio, or CAT scan angiography, is the gold standard for the evaluation of cerebral aneurysms. MRIs and MRAs are commonly done to assess more where a stroke could be, what vessels it's involving. The MRA is showing the arterial structures where a aneurysm could be. Common lab work is the CBC, complete metabolic panel, assessing their sodium and their glucose levels. ProTime INR PTT, assessing for any coagulopathies, if there's any alterations in their clotting factors. Their arterial blood gases, or ABGs, assessing for any hypoxia, or if their pH and their CO2. And toxicology screenings to assess if they are intoxicated, their blood alcohol level, if they were doing any illicit drugs like synthetic marijuana, cocaine, crack, any amphetamines, methamphetamines. You're assessing a 12-lead EKG or cardiogram for any arrhythmias or AFib. 2D echo is assessing for the functions of the heart, what their ejection fracture is, or if they're having any problems with their heart there. You're assessing the duplex carotid and duplex studies, assessing their carotid arteries for bruit or any narrowing. You're assessing a transesophageal echocardiogram, or TEE, to assess the patient if they have a clot or they have a patent foramen ovale or PFO or atrial septal defects. You assess an electroencephalogram, which is an EEG, assessing for any seizures, or sometimes that could also be a mimic of stroke symptoms, seizure activity. And you're also assessing a stroke patient for transcranial Doppler or TCDs to see if they're if the patient, you're assessing through the windows in their brain, their vessels, to see if they're having any periods of vasospasm. Common medical management of strokes: ischemic stroke, you're doing the NIH stroke scale. The physician assesses the patient depending upon their severity of stroke symptoms, if they also qualify for the requirements of thrombolytic medication within 3.5 hours of onset of stroke-like symptoms, and it's time-based, time-limited, and if the patient meets the criteria for alteplase or TPA. And alteplase or TPA is the only FDA-approved thrombolytic medication in the United States. If the patient does not meet the criteria for alteplase or TPA, they could have medical management of interventional radiology. Procedures are going in for a thrombectomy, which is a clot retrieval or removal of a clot or thrombus. They can go for coiling or stenting, or sometimes if a patient has an aneurysm that's so big that they can't treat it with interventional radiology, they can go to the OR for a procedure for an aneurysmal clipping. We're constantly monitoring ischemic stroke patients, their intracranial pressure. You take their intracranial pressure minus their mean arterial pressure, and you can get a CPP, that is commonly assessed when a patient has a arterial line, assessing their blood pressure that way. We're constantly assessing vital signs, making sure that the patient isn't febrile, if they're not having any cardiac arrhythmias, and their blood pressure, making sure that they're not hypotensive, that can cause spasm, or they're not hypertensive, that can cause increased potential for bleeding. You're assessing their glycemic assessment. Common medications for ischemic patients are antihypertensive and anticonvulsants, and I'm going to explain what they exactly are in just a little bit. Hemorrhagic strokes, you're doing ongoing neurological assessments. In the neuroscience intensive care unit where I work, we assess the patients. If they receive TPA, you're assessing them every 15 minutes for 2 hours, every 30 minutes for 2 hours, and then every hour. Same thing with hemorrhagic strokes. You're constantly assessing the patients hourly. Some of the medical management is an OR procedure for neurosurgery. They can go in depending upon where the hemorrhagic stroke is and the size of the hemorrhagic stroke to do an evacuation of the stroke or the bleeding in the brain, or do a craniotomy. And they can go to the extreme of a patient that is so severe that they are going to herniate and there's no other hope. They can go to the OR for a hemicraniotomy, which is removal of the skull bone, so that if the brain begins to swell before they herniate, and if they have no response to mannitol, like I explained, or 3%, they will go in there and remove the bone so that the brain can actually swell in the outside of the skull bone, so that they don't herniate. Like I said, again, you're assessing their vital signs, their temperature, their heart rate and respiratory rate, and their blood pressure. Common anticonvulsants are Keppra, Dilantin, and Cerebrex. There's more, that's just a few to name. Common treatment for hemorrhagic stroke, if the patient develops any cerebral or vasogenic edema, is hypertonic 3% saline. That helps to pull the extra fluid from the tissue. You're constantly checking their values to make sure that they're not hyponatremic or hypernatremic. The doctor will give you an order to check their BMP or their basic metabolic panel, assessing those levels. Your antihypertensives, you want to make sure if a patient comes in with hypertensive crisis or uncontrolled hypertension, you want to bring their pressure down, and you don't want to drop it too fast. So you could start them by giving them either labetalol, just to name a few, or metoprolol, low pressure, or put them on a nicardipine or cardine drip. And sometimes hemorrhagic stroke patients are put on vasopressor medications to maintain and perfuse the area of stroke. They're put on norepinephrine, which is Levophed, or they could be put on phenylephrine or Neo. They could be put on nipride. That's just a few medications, and some of the medical management of strokes. And it's always patient specific of what the patient is experiencing. Assessment and nursing diagnosis of the affected areas related to a CVA. These are just a few of the nursing diagnoses for either hemorrhagic or ischemic stroke patients. Ineffective cerebral tissue perfusion related to altered level of consciousness. Impaired physical mobility related to where their deficit is, their hand, their arm, their leg, their foot impairment. Ineffective coping related to impaired body image and lifestyle change. They can have self-care deficit related to impaired physical mobility. Alteration in sensory perception related to impaired sensory sensation. Potential risk for falls related to, especially the right-sided, that they are completely unaware of their deficit from the stroke. Their hand, their arm, their leg, and foot impairment or deficit or loss, or hemiplegia or hemiparesis. Alteration in communication related to change in speech. They could have alteration in nutrition, alteration in elimination. You can go on and on with the nursing diagnosis. Some nursing interventions for stroke patients. You're going to assess them from head to toe, all of the systems. Primarily, you're going to assess their airway patency. You're going to assess their oxygen saturation. For some patients that don't have lose airway control, they'll be ventilated, or they can be on Optiflow, which is high flow oxygen, or BiPAP, or just nasal cannula, or they could be on room air. You're assessing their arterial blood gases, their ABGs, always doing oral care for the patient. Like I said, commonly you're doing frequent neuro assessments on these patients, at least every hour or more frequent, assessing their level of consciousness, their neurochecks, their reflexes, cranial nerves, the Glasgow Coma Scale, and the NIH Stroke Scale. Ongoingly monitoring all their vital signs, like I've explained already. You're assessing the patients for dysphagia. You want to have head of the bed elevated at least 30 degrees, and assessing for aspiration precautions. Ongoingly, always addressing and assessing patients for nutrition and hydration. Again, you're going to have physical therapy, occupational therapy, speech therapy. Speech therapy is a big component here, where they assess the patient for their swallowing and making sure that they're not having any aspiration, putting them on the appropriate diet, ranging from pureed to sometimes leave them, if the patient has severe deficits, the patients aren't able to take any fluid at all or any nutrition. So if they're intubated, we put an oral nasogastric tube in them, or an oral OG tube to give them tube feedings, or we also can insert a Dobhoff that goes into their stomach to give them tube feeds in their medication, or sometimes patients, depending upon their deficits, can just need IV hydration. We're ongoingly assessing their skin for protection, especially if the patient's having neurological deficits or loss of extremity sensation. You want to ongoingly do range of motion so that they don't have any skin breakdown. You always want to promote safety for the patients, fall prevention, and seizure precautions. And then you're going to assess the patient for rehabilitation as needed with their activities of daily living. If they will be following up going to rehab, if they're going to they can potentially go home with home physical therapy, go to personal care, or go to a skilled nursing facility. I hope that you've learned something new about CVAs and strokes through this presentations. If you have any questions, I can be reached at my email at jbutsavich@pacollege.edu. I appreciate your time and your attention. Thank you.